We are so excited to have Dr. Jennifer Kask and Dr. Kirsten Duckitt, two maternity providers from north on the island from where we are, to talk today about preterm birth. The reason they're so passionate about this is if people come in preterm labor in their communities, they have to get transferred out, generally speaking, hours away from their own homes and support systems. So they wanted to really educate people on what are the signs of preterm birth in an effort to help prevent it, but also to decrease the challenges associated with being out of your own community for long periods of time when you have a newborn baby. So let's get into it after this quick reminder.
Welcome to the She Found Motherhood podcast. We are doctors Sarah and Alicia, maternity physicians and moms who have been through it all. We want to empower you with knowledge so you can have the best pregnancy, birth, and postpartum experience you can.
She Found Health and She Found Motherhood is meant for general medical information only. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. This information does not apply to every situation. If you have questions or if you've received different advice, please contact your healthcare provider. Always seek the advice of your physician or another qualified health provider with any questions you may have regarding a medical condition. The views expressed by She Found Health and She Found Motherhood and our guests are not representative of any of the institutions with which we are affiliated. Some of our podcast episodes are sponsored so that we can keep getting great info out there to you, our listeners. We only partner with companies that we truly believe in. Some of our links and suggestions may be affiliates, and we would appreciate you using them to help fund this important work. Now let's get to it.
We are so lucky to have Dr. Kirsten Duckitt and Dr. Jennifer Kask here to join us today to talk about preterm birth. So why don't we get off and you guys just tell us a little bit about yourselves, and then we'll chat a little bit about what got you interested in doing all of this work that you've been doing around preterm birth. Jennifer, why don't we start with you?
So I'm Jennifer. I'm a family doctor from Northern Vancouver Island, and I work in an area where preterm labor and birth means transfer to another hospital in another community. And our hospital has no nursery to care for preterm infants, so I'm passionate about reducing that occurrence for families. And the one thing I want listeners to remember from this is that if you have had a spontaneous preterm birth in the past, there are treatments to reduce your chance of another preterm birth in the future.
Awesome. Thank you. And Kirsten, why don't you let us know a little bit about yourself?
Hi, I'm a OBGYN. Until very recently, I worked with Jennifer up in Northern Vancouver Island. And having had a long-term interest in preventing preterm birth, in 2018, we worked together to develop a prevention of preterm birth pathway, which is now being spread to other communities on the island. But we particularly recognize that giving people information about this is vitally important. We can't always rely on healthcare professionals to necessarily highlight everything all the time. There's so much to consider during one's pregnancy.
Exactly. And there's a study down in the States that was done, I don't know when, but showing that kind of prenatal education actually can decrease preterm birth rates. And I just think that's probably part of the information sharing and helping to let people know what to look out for. So this podcast hopefully will do the same for people, pregnant people. I know you guys have a story of a pregnant person and preterm births that you were hoping to share that kind of will help us to understand a little bit more about it.
So this is a story of a pregnant individual from a remote community who had her baby in our hospital. Her first baby was born at term. It was an uncomplicated pregnancy. There were no concerns at all. Her second labor, about 2 years later, came on unexpectedly at 34 weeks of pregnancy while she was at home in a remote community. She was checked in their emergency department. She was taken by ambulance to the airport, which is the closest airport in our community. And so she was taken by ambulance to be evacuated to Victoria. And as she was going to be loaded on the plane, the doctor traveling with her in the ambulance checked her cervix, as we do before we start travel. And she was already in well-established active labor, so transferred to our hospital. And the baby was born within the hour. So 34 weeks, the baby was sent to the neonatal ICU and was there for a few weeks. She went on to have a third pregnancy about 18 months later. And when she went into labor at 33 weeks in her community, it went fast. So that baby was born in this remote community emergency department, probably one of the only babies born there in years, and was transferred by helicopter to the neonatal ICU and spent the first 5 weeks of life in the neonatal ICU. From 33 weeks, 5 weeks later, you're about 38 weeks corrected age, and that's sort of a normal time to go home. So understandably, when she came, she was concerned in her fourth pregnancy, and she wanted to do everything possible to prevent a similar birth experience. The risk based on her story, really, if you look at the statistics, it's around 33 to 42%. But given her story, she really felt it was inevitable that she was having her next baby early also. So she was started on vaginal progesterone. She had her cervix monitored with extra ultrasounds up to 24 weeks. She self-collected urine and vaginal tests monthly, and anything that came up positive on those tests was treated. So she came to our community early. And in fact, she went into labor one day before term, 36 weeks, 6 days. And when her baby was born, normal birth, placed on her chest to transition. And we did all the normal things. We dried him off. We did delayed cord clamping. We delivered the placenta. We started to clean up the room. And she just kept asking, she and her partner, is this it? You don't need to take him. You don't need to do anything else. And we said, no, this baby's just going to transition. And in fact, they were discharged from the hospital on day 2 of life and then went home to their community at day 3 of life. And you can imagine what a tremendous change that was for her and her family when you compared it to her last birth experiences. And she said, if my story helps to change things for other people, please share that.
Yeah, that's amazing. And I work in Victoria, BC. So we are the highest level of care on the island. So our NICU takes all of the babies over, I don't know, whenever they're born, really down to 22, 24, 25 weeks. We in our community are extremely privileged that we have that right where we are, whereas you guys up on the Northern Island don't have that. And so patients or pregnant people who come in early labor get transferred out of their homes, out of their home communities, out of their support systems, away from the providers that they've learned to know and trust throughout their pregnancy. So this is a huge issue for anybody. It's a huge issue wherever you are, but especially if you are in more rural or remote communities that don't have the capability of supporting a baby who's born early. And so that's why I think I get the sense that's why you guys are so passionate about this, because you recognize the huge impact this can have on a family's life, having to lose your support system and being transferred out of your home when things like this happen. So I just want to say thank you both for all of this work that you're doing. And coming from a urban center, I have worked a little bit rurally, and it scared the bejeebers out of me when those 34-week people came in labor into the emerge. But we recognize it. I think some of us don't necessarily recognize it as much as we should, but I think we recognize it and appreciate the challenges that care providers and families face in this situation. So why don't we chat a little bit about what does preterm mean?
So pregnancy is considered 40 weeks long. Your due date is the day at the start of the 40th week since the first day of your last menstrual period, or the date that your ultrasound tells you you're due. And term is the word we use to describe those 5 weeks when the babies are usually born between 37 and 42 weeks. So a baby born before 37 weeks is preterm. And premature is another word that's been used for those babies born before 37.
How often would you say that kind of having a preterm baby occurs? What are the numbers that we're looking at?
So the rates of preterm birth do vary depending on where you live. If you just look at Canada as a country, the rates are about 8% of babies are born before 37 weeks. So that means out of every 100 babies born, 8 will be early. But there are some regions where it's much higher. And we found that some of the areas that we were looking after in the north and the west of the island had much higher rates. It does vary a bit from year to year, but even taking that into account, we had some rates varying from like 14 to just over 20%, which is obviously much higher than the national rate of 8%. And this particularly caught the attention of Jen and I. And that was one of the reasons why we wanted to start this project. Jen still does a remote clinic every month right up at the tip of Northern Vancouver Island.
Yeah, and it's interesting, right? The differences between rates in different areas. Any sense of why that might be?
I think health is very different in different areas and in different populations. And we know that the more rural you are, even though we try really hard to have exactly the same access to medicine and doctors and health, it's just more difficult because of the distance.
And big differences in social determinants of health. I think we've kind of chatted about, right? And different ethnicities and cultures and stuff. But so I know North Island, I went up and did a couple of locums up at Port Hardy. And for anybody who is aware of Vancouver Island, which is off of BC, off of Vancouver, Port Hardy is 8 hours north of where I live in Victoria, and probably 4 hours north of Campbell River, where you guys are. And there's not a lot of, Jennifer goes up and does clinics there once a month. And so you don't necessarily have people with the expertise that is specific to obstetrical knowledge working up there on a regular basis. Although the docs up there are incredible, but just I don't have the expertise in old people medicine because I have a very young practice. Other people who don't do obstetrics frequently don't necessarily have the same level of expertise as those of us who do, because it is a bit of a specialized training. And so access can be challenging, and also access to educational options when you're more rural. You just don't have the same availability kind of to prenatal classes or courses that are offered in person. So I think that may be part of it as well. And also just cultural issues that have come up that perhaps make people a little bit more anxious or nervous to access the healthcare system because of the variety of things that they've gone through in the past, or probably some of those pieces, I would imagine. Hey?
And I should say that in the last couple of years, there's been a tremendous change in the North Island where there's a great group of midwives who are working up there, and that's really improved access for maternity care.
That's incredible. Yeah, that's so wonderful. And I think we need to really make sure we do our best as care providers to provide access to everybody, regardless of who they are and where they live. But that's also a challenge sometimes. So in pregnancy, we have two patients, right? We have the pregnant person, we have the baby that's growing inside of them. So why don't we chat a little bit about what the risks are to the baby? Let's start off, because that's often what we think about.
Yeah, the risks of preterm birth really do fall mainly to the babies. And being born too early is the leading cause of infant death and long-term health problems worldwide. This depends on how preterm the baby is when they are born. So the risk of a medical issue, they're all much different when a baby is born at 25 weeks versus 35 or more weeks. But we know that babies who are born at term or after 37 weeks will have more fully developed bodies. They'll be able to physically and emotionally bond better with their parents and their caregivers. They find it easier to breastfeed. They're less likely to have to stay in the hospital very long. And they have less of a chance of having those short-term complications that need specialized care in a neonatal ICU, like treatment of infections or breathing and feeding help. And they have less chance of long-term complications like heart and lung disease, hearing, vision loss, and developmental challenges. So it's much better to be born at the right time. And caring for preterm newborns in a neonatal ICU is really specialized care that's only available within a few centers in BC. So it is almost 500 kilometers to get from Port Hardy at the northern tip of Vancouver Island to the nursery in Victoria, close by to where, like in that same building where you work. And that is far away from family and friends and all the supports of home. And that's hard on families. Parents really experience stress when their babies are in the neonatal ICU. And so the biggest risk to the pregnant person and their partner from preterm birth is really the emotional toll that it takes on them. And the baby's having to be in the NICU, not with them after birth. And depending on how early they're born, that can be right up to their expected due date.
And a colleague and I, who both had babies in the NICU, mine was born at 37 weeks, but still ended up in the NICU for 3 weeks. We did a podcast around being a NICU parent and kind of some top tips. So we'll link that in the show notes below. If anybody is in the NICU or at a bit of a higher risk of having a preterm delivery, they can have a listen to that just to get a bit more perspective on what that could look like. But even for me, and my second was born at 37 weeks, ended up in the NICU. And just the challenges of being with my toddler and my newborn while living in the same center and having all of my friends and supports around was huge, let alone we chatted about it coming from a different area, finding somewhere to live, figuring out groceries, all of those simple pieces of the puzzle that we take for granted every single day. Everything becomes a challenge. And I think that can increase stressors in relationships as well, financial stressors. If you're having to go off work early and your partner's still working, or trying to just mitigate all of those relationship things with a newborn in the NICU on the top of it. So I think it's really important to make sure people are communicating well, recognizing that stress, reaching out for support, having their friends check in on them. There's always social workers in the NICU that you can ask for support around, but I think we we often we don't forget about it, but we focus so much on the baby that I think we need to also recognize the parents as well. And another thing is the trauma that goes around all of that piece. And we talk about birth trauma, and I think it goes really unrecognized to a lot of us. So making sure that you're acknowledging your feelings and talking to somebody about them is a huge piece of the puzzle that for parents is a big one. And then getting support with kind of breastfeeding or chest feeding around that if that's something that you're interested in doing, which I think, again, we certainly in Victoria can do a lot better at within our NICU population.
Hey, Sarah.
Yes, Alicia?
Do you ever find that people bring in their birth plans to show you in the office and they're not even hitting the important points?
I do. And I think that they don't even consider all the options when really we often don't have any idea of what to expect going into labor.
Agree. So what we did is we put together a free birth plan download, but we also put together a little course about how you can fill it out, talking about what the real purpose of a birth plan should be and how it can really help you have the best birth you can.
We've got an area that covers your medical history and your pregnancy, and then we've got a section that helps you walk through and figure out when you might accept certain interventions. Not just yes or no, but at what point and at what stage in your labor and birth experience.
We go over some examples through case studies to help you get an idea of what this could look like. And we also think it's really important to use your birth plan as a jumping off point for conversations with your partner and your provider. And we talk a little bit about how you can start doing this with our birth plan course.
Absolutely. If you're interested in learning more, head to our website, www.shefoundhealth.com/courses.
See you there.
So why don't we chat a little bit about how do we know if somebody is actually at risk of preterm birth?
So the biggest risk factor for preterm birth is having had a previous preterm birth. And of course, we know that at the beginning of a pregnancy, when we talk to someone and ask, have they had pregnancies before, what's happened with them? And also having, a second trimester loss, what we'd call a miscarriage, anytime up until babies are able to survive around 23 weeks, that might also be a risk factor. And then there are some other medical conditions, be people that have had procedures done on their cervix that perhaps leaves their cervix a bit more vulnerable to opening up early, or different shapes of their uterus. We know that getting infections during pregnancy can often lead to preterm birth. And of course, that's really topical with COVID, but also flu. And this is the biggest reason we ask people to consider vaccination in pregnancy, because both these conditions can be much more serious when you're pregnant and either leads to spontaneous preterm birth or having to be delivered early because of the mum's illness. We know that infections, perhaps bladder infections, kidney infections, can also lead to preterm birth. There's a lot we don't know. We don't even know exactly what triggers labor at term. And if we did, that might give us more clues. But certainly infections in general and local infections in the genital tract seem to be implicated in some cases of early to preterm birth. We also know that adolescent pregnancies, so if you're a teenager and pregnant, there's a higher risk of preterm birth. And lifestyle choices like smoking cigarettes, using marijuana, they can also be linked with earlier births.
So we chatted about how on your story that you told about the pregnant person with her 4 babies up north about decreasing risks of preterm birth. So what can we do to help decrease risk of preterm birth in those people who we are suspicious that they're at increased risks?
So all pregnant people can reduce their risk by attending prenatal visits, just like you were talking about right at the start, and being screened for infections and having them treated. Taking care of your overall health with a good diet, exercise, avoiding cigarettes, marijuana use, drugs and alcohol, they all make a difference. Good dental health is important. Brushing and flossing and seeing the dentist to have issues fixed, because a cavity is actually a little infection. Vaccination against influenza and COVID will reduce your risk of infections with illnesses that in fact increase your risk of having a preterm birth. And then spacing your pregnancies also reduces risks. And most experts will say that having your kids' birthdays around 2 years apart reduces your risk. Of course, not having your kids' birthdays too far apart.
Yeah, so I think the numbers are 18 months to 5 years is that optimal kind of interpregnancy interval. Yeah.
And then we know that testing more frequently for the infections we were talking about, so urinary tract infections, genital infections, and treating anything. So even in women at high risk, treating things like yeast and bacterial vaginosis, which is this kind of imbalance of bacteria in the vagina, it might not be so important if you've not got symptoms and you haven't had an early birth before, but it certainly is important if you've got that kind of history. One of the things that might be recommended is to monitor the length of the cervix. And if the cervix looks like it's particularly short in between 16 and 24 weeks of pregnancy, that can also be an additional kind of risk factor for giving birth early. And then we've had we've been doing this for a while, but there's also been some updated national guidelines recently that really recommend giving a drug treatment, a hormone treatment called progesterone, to women who've had either a previous early birth or have had a short cervix on these ultrasound examinations. And progesterone is a hormone that the body makes naturally. It's made by the placenta, it's made by the ovaries. And it's interesting because it seems to do a few different things. It seems to be connected with how contractile the uterus is. So it dampens down contractions of the muscle in the uterus and might reduce starting off labor that way. But it also has an anti-inflammatory effect and an antimicrobial effect as well. We're not entirely sure how it works, but it seems to reduce the chance of going into early labor by about half, regardless of whether you're using it because you've had a previous early birth or you've got a short cervix.
And this is a vaginal medication. So this is something that your provider would prescribe and you would use vaginally daily up to a certain point, depending on.
Yeah, it's used in other medical conditions as an oral preparation. And it's the oral preparation that we're asking women to insert vaginally. That does seem a bit odd, and you may need to get your head around that a bit. And also it's not really reflected in the package inserts because the written stuff that comes with the medication is really aimed at people using it for different reasons. There has been interest in using progesterone maybe as an injection for this too, but at the moment that's not what's been recommended. So these national guidelines definitely recommend vaginal progesterone.
I remember my sister-in-law 8 years ago, she had preterm birth in the States. So they were giving her injections of progesterone. I was like, oh, I've never heard of that here. Still haven't. But yeah, we use the oral exactly preparation vaginally. Thank you for clarifying. So let's chat about the signs of preterm labor. And I think this is a really important thing to focus on and pay attention to because we can't always stop preterm labor, but sometimes we can delay it enough that we can help support baby to do better when they're born, if they're born early. Jennifer, do you want to talk a little bit about what are those signs that we recommend pregnant people keep an eyeball out for?
Unfortunately, those signs of preterm labor aren't always obvious, and many pregnant people with similar symptoms aren't actually in preterm labor. So I would really say that if you are experiencing the symptoms that we're going to talk about, just reach out to your care provider. We would rather hear from you about symptoms that are potentially concerning so that we can determine if you're at risk of preterm labor, because sometimes we can prevent things from progressing. And if people don't speak up about unusual symptoms, then we can't do anything to help. So if you're concerned about symptoms, talk to your care provider. Some of the symptoms your care provider would want to hear about are increasing or unusual lower back or pelvic pain or pressure, menstrual type cramps that are happening regularly and that don't go away with rest. So, for example, you're paying attention and you're getting cramping every 20 minutes, every 10 minutes, every 5 minutes. It's going on for over an hour and they're not getting better or going away. We want to hear about that. Fluid leaking or bleeding from the vagina always needs checked out. Yeah, of course, sometimes it's that you peed your pants, which is super common in pregnancy, but still, if it's ongoing and not just a one-time thing, it needs to be checked out. If you are worried that you have a bladder infection or if you're having diarrhea for no good reason, get some advice. The uterus can be irritated by the organs around it, and it can irritate the organs around it when it's starting to become more active. So listening to your body, reaching out to your provider for advice when something doesn't feel right is always best for you and your baby.
And then if you do reach out to your care provider and either they ask you to come and see them in their office or come and meet them on the maternity ward, they're going to listen to what you say, ask you about your symptoms, how long they've been going on. And then there are various tests they can do to see if there's something to worry about or not. So you may get a speculum examination of your cervix. You may get various swabs taken, both for infection and for some tests that can perhaps help predict whether you're going to go into preterm labor or not. And you may, depending on where you are and depending on exactly the right circumstances, you might get an ultrasound again, looking at the length of your cervix or just making sure baby's all right. And then some of these things depend where you live. So just like you were saying, if you're in Victoria and you do deliver early, it's not such a big deal as if you're in a place where there's not a NICU. So sometimes these things differ slightly between where you live. And then if there's a strong worry that you are going into early labor, you may have to be transferred either down island to Victoria or sometimes even off the island to the lower mainland, depending on where there are beds in the neonatal unit. And at that point, if that's a real worry that you're going to deliver early, you may get some medications, both to help baby if baby's born early, but also to maybe stop labor. Not that it necessarily stops labor forever, but just stops labor enough so that you can get to a safe place for delivery, and also prolong labor a bit so that some of these medications we give for the baby are going to be a bit more effective.
Yeah, so certainly for babies under, I don't know, 32, 34 weeks, we give them a shot. We give pregnant people a shot of steroids. And what that does is it helps mature babies' lungs and decrease risks of bleeding in the brain and bowel infections and those types of things. And we ideally want 48 hours to give those some time to work. And so sometimes we'll give some medication to help stop the labor for those 48 hours to see if they can work. If it keeps stopping it, great. But sometimes then we'd stop the medications and see what happens. And then oftentimes we'll give a little bit of fluid because sometimes if you're dehydrated, it can increase risks and make sure there's no urine infections and those types of things. And that's pretty consistent, I think, regardless of where you are. But certainly sometimes we don't have ultrasound availability depending on communities and those types of things. So then it would be advised to, for the safety of your baby, transferred to somewhere that they can provide care. And sometimes things don't progress and everything settles down and you can go back home, but sometimes they do progress. And then it's best to be in the safest environment to give your baby the best chance at doing well long term. Yeah. So there you have it. That's a quick and dirty preterm birth chat. Thank you both so much for joining me today. It's really an amazing initiative that you have both done. And I think it will help prevent these preterm births and the challenges with families and especially in rural communities like where you guys practice for years and years to come. Thank you both for all of the work that you have done and are continuing to do around this and for coming on and chatting with us about it today.
So much for inviting us.
Thanks for listening. Make sure to check out our website at www.shefoundhealth.ca and to sign up for our community for weekly bump blasts. Make sure to check us out on Instagram or Facebook at she.found.motherhood and head on over to your favorite podcast app and leave a review and a 5-star rating. If you enjoyed this podcast, take a pic of yourself listening to it and share it on social. Make sure to tag us on it so we know to keep making them.